Ready? First and foremost, I'd like to thank Dr. Iyengar for having asked me to be part of this meeting. Dr. Iyengar is somebody who's always been interested in teaching, and wherever he has been, there has been teaching. That much I can definitely guarantee. And I was one of the privileged ones to have been his student in my initial MD days. So when he asked me to be part of this, I said definitely yes, sir. And today we're going to have Dr. Ajay Swamy, who's going to speak to us on the transseptal puncture theory and practice. I do remember that when I went to Vellore and we used to look at the old recordings, in the olden days, they used to, the basic idea of accessing the left atrium was to measure the pressure, and they used to do it from the suprasternal puncture, And I have still seen some cines of that and some pictures. I do remember those huge cines, and we used to wonder how, that they used to do those things. Then, of course, I think our era of cardiologists, I think abroad for some time, transseptal puncture went out of fashion because there was not much of use for that. But whereas a era of cardiologists in India did a lot of septal punctures because of balloon mitral valve water. So a rheumatic heart disease and balloon mitral valve water. But as Dr. Iyengar said, in the last few years, it has really made a big comeback, and it has become an essential part of training of the cardiologists because of one is for electrophysiology. I think every electrophysiologist is very, very adept at because of atrial ablation for atrial fibrillation. Then, of course, the left atrial appendage occlusion has come into play. And then, of course, now structural heart disease, mitral valve clipping and mitral valve repairs. So there are a whole lot of indications. I'm sure Dr. Ajay Swamy, who's going to be our speaker today, a very senior cardiologist, who's now the cardiologist at Command Hospital and has been at various positions in the Air Force group, wherever he's worked in Pune, he's worked in Delhi. And the Command Hospital has been very fortunate to have him with them because he's really helped, along with some of the other people, to develop this program at Command Hospital. In Bangalore, having a huge population of ex-servicemen serving people, they get the best of cardiology treatment because of the cardiologists that have been at Command Hospital, and Dr. Ajay Swamy belongs to this illustrious group. So I won't try and stand for very long because I'm sure that he's going to really give us a very good theoretical and practical view on transseptal puncture theory and practice as he's labeled his lecture. Over to Dr. Ajay Swamy.
Thank you very much, sir. Before I begin, my salutations to my teachers, some of whom are here. Dr. Iyengar has been my teacher since I joined medicine, since my internship, and Dr. Naik, coincidentally, I think he's done his MT from Command Hospital, Bangalore, but we've known him for the last decade and a half. And Dr. Patil, I see also on the screen, who was the examiner for one of my colleagues, Dr. Keshav. It's a great pleasure to be here. And we're going to speak for the next 45 minutes about transseptal puncture, theory and practice. And it's amazing because this particular procedure actually parallels the development of cardiology over the last half a century and beyond. We're going to look at the gross anatomy, the fluoroscopic anatomy, the echocardiographic anatomy, and the intracardiac echo anatomy of the interatrial septum, and how we get past it. Now, this is what the gross anatomy is like. This is a simple picture taken from a dissection hall. And this is when one looks at the heart from in front, and you see that there's the SVC, the right atrium, the right ventricle, the RVOT and the RV apex that we see anteriorly, the aorta and the SVC as we see from above. The interatrial septum development is also something that we all know. The septum primum develops from superior to inferior, and the septum kind of resorbs superiorly, and the septum secundum develops from inferior to superior, and the inferior part resolves, leaving a narrow channel, which actually in utero allows shunting of blood from left to right, and thereafter closes off once the baby is born, sometimes leaving a small PFO. But the narrowest part of this septum, the foramen ovale, is the part where we usually try to do the septal puncture because it's the thinnest part of the interatrial septum and the safest part where one can get from the left side of the heart to the right side. The challenge is that there are so many other important structures all around us. To identify them and try and make a safe puncture is the challenge that one needs to do when one does this transseptal puncture procedure. If one looks at the right atrium from the right side of the heart, these are the structures coming from above downwards. The aorta and the SVC that are next to each other. The SVC drains into the right atrium, and in a straight line down from the SVC is the fossa ovalis, and straight line down is the IVC. To the right of that, inferiorly, we have the tricuspid valve. Just above that, the coronary sinus ostia, and vertically above is the right atrial appendage. Now, this fossa ovalis is the most important and the most stable part of the interatrial septum. It is stable with respect to the other structures in the heart, but not always so with respect to the bony prominences and the other skeletal prominences that we have because of the other abnormalities which could be there developmentally. As we'll try and see as we go along, how we identify where we need to get from the left side to the right side. Now, why do we need to do this? Although this is by no means a complete list, this essentially summarizes the reasons why we need to do it. As Dr. Ranga said, cardiac catheterization was the first indication and one actually needed to measure pressures in the left side of the heart as to why we needed to do this procedure. The balloon mitral valvuloplasty then took over as the most important procedure one did with this. Electrophysiology for left atrial tachycardias, for atrial fibrillation ablations, for exclusions, for left-sided pathways, and so on and what have you, was the next indication. Structural heart interventions have taken over the last decade and a half, whether it is LA appendage occlusion, closure of a paravalvular leak, use of the mitra clip, presence of the tandem heart, doing a valve-in-valve, and so many other procedures which can be done, which can't possibly be put on one slide, but this is just an overview. What about the contraindications? When should we definitely not do it? There is only one hard contraindication that has been mentioned everywhere. And it's true also. That is a free thrombus in the LA because one might dislodge it and end up sending it into a more important structure, into one of the coronaries or into the cerebral circulation, and then end up with a bigger problem than we begin with. There are relative contraindications, but with expertise and imaging, one can get past all of these. Distorted anatomy of both the interatrial septum as well as the aortic root dilatation, patients who have undergone atrial septal repair because of surgery, interrupted IVC, all these can be got past by one way or the other using different techniques. Now, historically, as Dr. Ranga said, this is the first description. This is an extended suprasternal puncture technique. And in this, if one thinks about it, it seems more like a horror show where someone puts a needle from the suprasternal space and tries to enter the left atrium by going through the right atrium. And so many times during this procedure, I took the liberty of going through their descriptions. They have hit so many other structures. They've hit the aorta, they've torn the SVC, but patients actually didn't do all that badly. And this is the evolution of the procedure after the initial hemodynamic assessment of the LA and the LV invasive pressures with these needles. In 1984, the percutaneous balloon mitral valvuloplasty came, then the pulmonary vein isolation for atrial fibrillation, then early 2000s, the left atrial appendage occlusion, the LV assist devices, the tandem heart, etc., which came later. And in 2012, the valve-in-valve procedures, the transcatheter mitral valve replacements and the valve-in-valve implantations. Now the transcatheter mitral valve repair in 2008, paravalvular leaks in between. Now, fluoroscopic has guided transseptal punctures for longer than echocardiography, and thus all the initial descriptions till about the late 80s were mostly with fluoroscopic anatomy. And I'm just going to look at the two ways in which it used to be done earlier and what we're going to do today. Fluoroscopic views are mandatory for all of us to be familiar with, and it's a 2D technique. So one must always at least use two views with idea of what all structures we're going to see from superior to inferior and left to right in all the fluoroscopic views. Now, this was the earliest way in which it was done, in which an RA angiography was done with an angled pigtail or with a plain pigtail. This helped to identify the tricuspid valve, the interatrial septum, where the SVC and the IVC ended. And then a pigtail was placed into the aorta. With time, the right atrial angiography technique has been superseded. Remember, these were the days in which there was only fluoroscopy and there was limited movement of the C arm. with knowledge of the RAO and the LAO and the lateral and all the structural, the anatomic and structural landmarks which have come in fluoroscopically, the RA angiography is not performed unless there is a gross structural abnormality either in the position of the heart or in the position of the skeleton or in the position of the great vessels or in patients with dextrocardia, etc. What we now do is just place a pigtail into the aorta, use that as a fixed landmark along with the skeletal prominences that we have. And I'm going to try and show you how we do that in a routine BMP or a routine transseptal puncture. And then look at the variations. It's first important to know what the basic technique of transseptal puncture is. So the basics are that we essentially access the systemic venous system, perform the septal puncture around the fossa ovalis at a place that we choose for our particular procedure, place a catheter into the LA for further intervention, pressure measurement, other interventions, etc. I'm not going to touch upon heparinization, etc., because they're different for different procedures and they are specific to that particular procedure that we're going to perform. The access is conventionally the right femoral vein because it has a straighter course to the right atrium. Rarely the left femoral vein can be used if there is a problem with the right side. Even jugular access has been reported even for BMVs as well as for so many other procedures, but they're only to be used with additional imaging. The basic anatomy when one goes from superior to inferior is this. From the SVC, we come down and you see the bulge of the aorta makes into the right atrium. If we come vertically down further, as we face the back of the left atrium is the foramen ovale. Down and to the right of that is the coronary sinus, and then below that is the IVC that we see in this particular slide of the basic anatomy. This is the Inouye technique. In the 45-degree RAO projection, these are the anatomic landmarks, and this is the simplest and the most straightforward way of figuring out where the SVC joins the right atrium, where the first bulge of the right atrium then over the aorta falls into the fossa ovalis, then into the tricuspid valve, then down into the inferior atrial boundary. And this 1 to 3 centimeters beneath the lower end of the aorta is the conventional landmark that one uses to guide where the fossa ovalis is on the short RAO view for 30 or 40 degrees RAO projection. This is an animation that one sees. You see 3 movements when one comes down with an angled catheter down from the superior vena cava down to the IVC. First is when the IVC drains into the right atrium, the first movement to the right. As we come down further over the limbus, another slight movement to the right where we fall over the aorta into the fossa. And third is the abrupt movement medially into the left into the drop when the catheter drops into the fossa ovalis. Now the transseptal puncture, this is how we start. We start the position in the SVC, always over a wire, slowly bring down medially over the atrial septum into the right atrium. You have an abrupt medial movement into the fossa ovalis, the third movement. The needle has thus been designed with a marker which shows where the curve is. And this curve tells us in what direction the needle points. As one faces the feet of the patient, looking from his foot between 3 to 6, usually around 4 o'clock, as one sees in the animation, is the direction that one needs for the needle to actually drop into the fossa. And this is in a normal size or not an extremely enlarged left atrium. The left atrium, when it enlarges posteriorly, and this becomes more and more vertical, the direction of the needle as one needs to go into the fossa, into the left atrium. This is the Brocken-Brown needle. This has a BRK and a BRK1 and an XS with 4 lengths, 71, 89, and 98 centimeters, depending on the height of our patient. The angulations are pretty much similar. However, the bevel of the needle is slightly different. If one looks at the XS side view, it has a steeper primary bevel angle and so a narrower angle. And less force is required to actually puncture the interatrial septum when one uses this particular needle, because it creates a thinner leading edge of material that doesn't require so much of puncture force, unlike the BRK side view. These are the bevel from a different views. There are also added oblique angles to create a sharper points. This also prevents us from having to push very hard and then prolapse too much into the left atrium and sometimes hit the posterior wall or lacerate another part of the left atrium, which is not a very great idea because there are so many important structures that one could cause damage. there. Now, this is how we prepare the whole system. The pointer flange shows us the tip orientation, as you see on the left-hand top corner. The transseptal, he's shown the sheath, but we normally put this needle inside the dilator. The whole system is flushed. After it is flushed, the stopcock is turned off to prevent any air embolizing into the whole system. Thereafter, syringes and heparinized saline are used to flush all components. The dilator is placed in the sheath if one is going to use a sheath. We place the needle inside this dilator and measure the stillet to the tip length. Now the needle is pulled back proximal to the dilator, keeping a marker there so that we are always in control of the tip of the needle, and the tip of the needle never protrudes beyond the dilator, so that one has control over how much one needs to put. Usually the left hand finger will mark this position, and that position remains the same. The distance from the pointer flange to the dilator hub. So there are also guards which can be used, but most people just use a finger. The foreign operators often use a stylet for the needle, but in our labs, we just use a 2.5 ml Luer lock syringe that is attached to some contrasts so that one can inject through that as and when required. As we've already spoken, the flange of the needle, the pointer shows us in which direction it is supposed to be looking at. Thereafter, you can always check that pressure lines can be attached to the back of the needle when it is ready for use, and you can always inject contrast to it. During the drag, as is shown on the left-hand bottom corner, this distance between the needle and the hub of the dilator must always be constant and maintained all through. As we have spoken again, there are three movements. First, after putting the wire into the left subclave, when we come down with the wire, leave the dilator there. Now advance the needle short of the tip of the dilator and start dragging it down. The first movement is SVC to RA, a slight movement to the right. Then over the limbus where the aorta is within the right atrium, slight movement to the right. And third, there is an abrupt movement to the left when it drops into the fossa ovalis. And thus we have, that is where we should now be feeling the pulsation of the aorta over the fossa. We check in all the three views, the AP, the RAO, and the LAO, and you can see the diagram on the right bottom corner of each of these AP and lateral views, which is going to try and show, which is going to try and show what is the position of the needle with respect to the other structures. My pointer isn't working, so you can still see that there is a 1 to 3 centimeter gap between the lower end of the pigtail and the upper end of the needle in the AP view. Also in the RAO view, you must see that this needle is pointing away from the aorta and away from the pigtail. Same thing in the lateral. If one draws a line from the non-coronary cusp to the spine, this should be in the middle third of that line, and that is what one needs to see on the lateral. The LAO we will see exactly, because the LAO is the view in which the interatrial septum is profiled the best in the middle of the screen. I've shown the AP, or to some extent the RAO and the lateral view. Again, to show what happens, this is the starting position of the needle in the SVC. We slowly pull down medially over the atrial septum into the RA, and it abruptly moves into the fossa ovalis. You can see that this dilator and the needle and the sheath complex is now in the thinnest part of the interatrial septum, pointing at 4 o'clock when one looks at the flange of the needle in the LAO view of the X-ray. Aortic pulsations here may be palpable. A short, sharp movement with the distance between the hub of the catheter and the needle being maintained. We ensure that the needle is in the left atrium now, because it is a good idea to be sure that the needle is in the left atrium before pushing in the dilator or the sheath. By mistake, if the needle punctures any of the other structures, if it's only the needle, most of the time no damage is done and you can come back easily even at this stage. How do we know that the needle is in the left atrium? First, the color of blood aspirated is bright red, because this is completely saturated blood. Next, we inject a small puff of contrast in the lateral view, and you can see that it's going off into the posterior part of the left atrium. And the pressure tracing, when one connects the pressure to this tracing, is that of the left atrium with prominent V wave if the patient is in sinus rhythm. Once that is sure, one can pull the needle back and advance the dilator. Thereafter, we withdraw the needle and advance the dilator. and place a wire in the LA. Now, for the conventional septal puncture needles, this is the special wire that comes along with the Inouye balloon. But there is another wire called a safe sept wire. So this goes through the needle. It has a very sharp tip and it curves on its own. This is what the electrophysiologists abroad use. It's a very, very safe and nice wire because the moment it exits the needle into the left atrium, it kind of curves. It's like our jalebi wire only. The Mullen's dilator followed by the catheter can be placed over the needle a little bit. The alternatives, sometimes it's very, very difficult to puncture the septum if the septum is slightly thick, or if the needle that we have used, sometimes we have to repeatedly reuse the needles and it doesn't go through the septal, the interatrial septum. Then a reverse end of an 014 wire can be used. Sometimes one has to puncture the septum at a different place from the fossa ovalis, as for a left atrial appendage occlusion. You need an inferior and a posterior puncture. Sometimes the reverse end of an 014 wire works just as well. You can also use RF ablation, something called a Bowie cautery, to the hub of the septal puncture needle that will allow it to go through. This is the alternative. One could also leave the Mullen's catheter there and directly use an RF ablation catheter or an RF ablation needle, both of which are now available in India as well. Thereafter, we cross and then complete whatever procedure we need to do. There are 5 essential rules for septal puncture. We always start in the SVC and come down. Never, never, ever go without the guide wire. Never with the dilator and sheath alone. Always with the wire when comes from superior to inferior. If you don't know where you are, it's always better to start over again. And if you think you've already crossed the IAS, but you cannot aspirate, just pull back a little and try. Otherwise, start all over again. Anticoagulation is an important part of this procedure. And most of the time, most operators whom I have worked with would always give anticoagulation after dilating the interatrial septum and they're sure that the systolic or the systemic pressure has not dropped. The timing of the anticoagulation, as I said, is different for everybody. However, it is dangerous to leave hardware in the left atrium without anticoagulation. So it's important to get this done early to make sure that we have a safe puncture and that we should be able to give anticoagulation quickly. There are potentially difficult patients with distorted anatomy with chest and spine deformities like scoliosis, in whom all the landmarks that we use are actually different from normal. Patients with congenital heart disease, in which one must use special imaging or special techniques to make sure that we are at the interatrial septum before puncturing it. Severe valve abnormalities that lead to gross changes in the sizes and the location of the chambers and the other landmarks that we use. Patients who had AST closure devices already done or AST surgical patches in places which are sometimes difficult to puncture, sometimes with a floppy septum with an elastic flap valve which can be tented, and when one tries to puncture it, the tent will go all the way up to the lateral wall of the LA, but we'll not be able to puncture, and we actually go through the LA itself, the lateral wall, when trying to puncture it. A previous transseptal puncture, which instead of making it easier, can sometimes make it more difficult because it makes it, each time it goes through the same puncture. And sometimes there is a fibrotic flap valve, which is extremely difficult, and this finally requires an RF ablation only to cross. Now, in case we have a difficult puncture, there are certain techniques which have been described. We can use the tattoo of the fossa ovalis by contrast medium injection and visualization of the foramen ovale by tenting with imaging in addition to angiography. You can use an RA angiography in an LAO view that will actually delineate the septum and leaves you with a stop go. You can actually wait for the contrast in the same view to come back into the LA, and with the RA you can actually wait for the contrast to come back into the LA. That will show you where the interatrial septum is. One can do an in addition a PA injection and wait for the contrast to come back into the LA. So you'll have the RA and the LA both filling, and then you can see exactly where the interatrial septum is. There are techniques where intracardiac echocardiography can be used to identify the location and the correct position for the transseptal puncture. This transesophageal echocardiography, which can always be used, and the right transseptal perforation, RF transseptal perforation, which we've already spoken of. Now, echocardiography is an important addition to our tool, and this has made this particular procedure extremely simple. It guides our transseptal puncture for so many other procedures that one has to perform on the left side of the heart. Essentially, we have the same anatomy, And this is the way in which we identify it. We use 0, 45, 90, and 135, 4 views for identifying the interatrial septum. This illustrates sometimes how difficult it can be. This floppy thin septum primum, the floppy part, can get tented right up to the lateral wall, and so it's very, very important to try and puncture this just where the junction is, so that you have some kind of counter traction for crossing over with your needle. Now, after identifying this, you can either give contrast and look in 90, or when one looks at the anterior superior and the posterior superior and the anterior superior part of the septum, identify the junction between these two, which is where it can be punctured. This is the short axis in 45 that tells you whether you're anterior or posterior, depending on where you want to puncture. And this is the tenting of the interatrial septum that one sees when one has to put in the catheter over this part. This is the bicaval view with the SVC and the IVC, and this is the aorta, which shows you whether you're going to be more anterior towards the aorta or more posterior away from the aorta in 45 degrees. These are essentially the 4 views on the echocardiography that will tell us where we need to puncture the interatrial septum. This is the same thing in a different view. The bicaval view showing us the tenting. This is a representation of what the fluoroscopy shows as well as what the echocardiography shows. This is what one looks at when one sees in the short axis. You can see the difference between the pigtail and the septum. And the same thing, if you imagine that is the aorta, and this opposite side is the superior part of the left atrium, that's where one would puncture. This is the safe sept wire, as I said, where sometimes you don't need a needle at all. You can just use this safe sept wire and cross. This is a narrow and a small, the tip is extremely sharp, and after about 30 millimeters approximately, it becomes strong. So it will support the positioning of a dilator and sometimes even the sheath across the interatrial septum. This is how the puncture is done along with a TE probe in place. Remember, all hardware is advanced over a wire only, even in the right side of the system. And then thereafter, after puncturing, one crosses easily. In this, there is no requirement of looking at the different RAO and the LAO views. There is also newer techniques like the echo nav, in which the echocardiogram is superimposed onto the angiogram. And I believe this technology is available with Manipal Hospital. You can see right lower half of the screen, you can see the image showing the echo being superimposed onto the fluoroscopy. And you can see the echo where it's actually moving, and you can puncture exactly where one wants to. You can visualize all the structure and puncture with the echo superimposed on the angiogram, and it makes the whole procedure exceedingly safe. This is the heart navigator. This is the 3D mapping of the interatrial septum that one can do. Along with this, these colored dots that you see actually map out. They are markers which are placed and they are superimposed onto the fluoroscopy, and one can puncture with these two. You can see these 2 dots being placed, and you can see the interatrial septum being punctured in between them with absolutely zero fluoro movement. There are also steerable sheets which one can place, and one can use these sheets to decide exactly how or which part of the interatrial septum to puncture and go above and below under transesophageal echocardiographic guidance. There is also intracardiac echo. Now, this is a large 18 French catheter which is placed in the right atrium, and it identifies all the right atrial structures. It identifies the fossa and the aortic root at the same time. Unlike the transesophageal echo, it doesn't come anywhere in the way of the X-ray equipment. There is no obstruction of fluoroscopy caused by this, which sometimes happens when one has a TEE and one is unable to actually get all the imaging information from the fluoroscopy as well. The disadvantages being that it's a small field of view and we actually move during manipulation of the transseptal sheath. But this is what it looks like. This is the ICE catheter, and you can see this is placed in the right atrium, and that's where the interatrial septum is. You can see the transseptal sheath tenting the fossa with the catheter in place perfectly. You can give a small injection and show contrast injected into the septum and tent it. And this is the needle across and the sheath across the septum. Now, complications, these are the they're always better prevented than treated. Pericardial effusion and tamponade for obvious reasons. You can have an RA and an LA needle puncture if one is not careful and one doesn't actually appreciate the anatomy, especially a stitch artifact. When the left atrium becomes extremely large, superiorly and laterally, one might go where there is actually no interatrial septum and go from the right atrium into the pericardium and then from the pericardium into the left atrium. And then one doesn't realize this until one has actually dilated the interatrial, or what one feels is the interatrial septum. So in such a situation, it's sometimes better to finish the procedure with a balloon and then leave the dilator and send the patient for surgery in case tamponade does occur. Aortic puncture and perforation, if one is not careful where the needle is pointing and by mistake the needle punctures the aorta instead of going across the interatrial septum. Air embolism or a TIA in case the system has not been flushed properly. A large ASD, which can sometimes be a problem, especially with the newer structural heart interventions. Transient ST elevation, which could either be because of air going off into the left atrium or a small thrombus going off into the left atrium and finding its way to the RCA, which is the usual problem, or which is the usual, how do we say, end point of air or thrombus going into the LA. Important thing to remember that this procedure is potentially fatal. So one must exercise all caution while doing this particular procedure and continuously pay attention to what is happening. If one looks at 5,500 transseptal procedures over 10 years, this is a large set of data. Out of 1,764, they didn't have any deaths, but there were 0.79% of complications. 3 perforations, 2 with tamponade, 1 needle puncture of an aortic root, 1 needle puncture of the right atrium, 4 needle punctures of the right atrium, 1 thromboembolism, and 3 transient ST elevations. Although this is an old study, but it does show that by no means is this procedure completely free from complication, but with attention to detail, they can be kept down to an extremely low incidence. In conclusion, knowledge of anatomy of the interatrial septum and relationship of the interatrial septum with all other structures can lead to a safe and appropriate transseptal puncture. Essentially, knowledge of the hardware, the anatomical landmarks, and imaging guidance, all 3 together will make for a safe puncture. These are the various different kind of procedures for which septal puncture can be done. This is for a mitra clip in which one needs an inferior and posterior puncture, which is about 4 to 6 centimeters from the mitral valve. This is obviously guided by imaging, that is the transesophageal echo. For transcatheter mitral valve repair, this is demonstrated safety and it's been used more than 30,000 patients worldwide. For a paravalvular leak, depending on the exact site of the leak, one looks at where one needs to puncture. A little more superior in case it is on the lateral wall, and a little even more superior in case one needs to go on the medial wall. Instead of this is an extremely successful and a simple procedure, and it has made a very dangerous and a problematic problem, sorted out this problem extremely effectively by use of various devices to close. These are the different sites of transseptal puncture depending on the procedure. For a PFO closure, for a mitra clip, for a percutaneous LV assist device placement, which is right in the center of the fossa, LA appendage closure, inferior and posterior, and for pulmonary vein interventions. Adventurous people have also performed this procedure on transthoracic echocardiographic guidance alone. And Dr. Vijay Trehan has performed a series of such interventions in which he has not used any fluoroscopy at all and used only echocardiographic guidance, especially in pregnant women. And he's published a series in Journal of American Society of Echocardiography after describing it first in Cath Cardiovascular 20 years ago. I think we should be an interactive session, so I hope we'll get a little more questions, and thank you for your attention.
Thank you, Ajay, for that very precise and excellent talk. I think a lot of the postgraduates here are there definitely benefit by the theory and what the various practical uses. And of course, I think one other important thing I think is that when you do this I think we should have, should just not, we should be ready for just drain at any time in case that you have a pericardial tamponade. I think you should even prepare the subcostal space and keep a set ready for in case you want, because I think that is the crucial thing, and we should be very proficient with that also. I mean, as a team should, the echo machine should be in the labs. Of course, what is your thing about in primary I mean, going a little bit off. I mean, now you've given a lot of things on how to do this transseptal punctures. What about primary pulmonary hypertension? What is the, I mean, that I did give a lot of, you said there are some more slides that would be required. What about primary pulmonary hypertension and the role of septal puncture?
So there are niche uses for transseptal punctures, which are there for various procedures. And patients with primary pulmonary hypertension who have syncope, this is the hard indication for a balloon atrial septostomy in such patients in adults. So what happens is that such patients who have got such severe pulmonary arterial hypertension that it leads to syncope or pre-syncope, and they're extremely symptomatic. One of the ways of relieving their symptoms is kind of blow off the right atrium and make a little transseptal puncture and a small hole there of about 3 to 4 millimeters. And people use balloons also, and they use the Rashkin procedure. And there are so many other procedures which you might describe. Essentially, it helps the patient relieve symptoms due to syncope, but gives him additional right to left shunt. So such patients become a little more cyanosed. So they'll kind of be palliated for some time. But that's in the long term, you end up with a little more cyanosis in such patients. And this used to be practiced about 20 years ago, but the newer prostacyclin inhibitors and PDE5 inhibitors have actually made it pretty much because they give such excellent pulmonary vasodilatation that this procedure not being done very much nowadays. Most of them die of chronic heart failure or complications. But definitely it was a procedure that used to be done 15, even we have done 4-5 of them. And but this is what we found, that they would develop more and more cyanosis, although the syncope and the pre-syncope used to come down.
I think going back, I think the most important thing that point that you have, I think the postgraduates should reply is what you said. I mean, there is always the temptation that you have the sheath in there to just, you slip out and you come down into towards the tricuspid valve, and you slip into the right ventricle. Just take it back and try and puncture all over again. I think is the one very, very important point. I think we should start all over again. Get the wire back into the SVC, go right up, take the sheath right into the, and then start coming down all over again. I think that is a most crucial step in terms of to prevent complications. I mean, when there are a lot, you might see a Dr. Manjunath or just pull it down, just flips it, goes in, and he just punctures it. But or Ajay doing it. But I don't think the undergraduate or the postgraduate person who's doing it I think for the first at least 100 punctures should be be very, very careful, knowing that where exactly you may not go. The people who are doing it repeatedly every day, who have done 5,000 balloon mitral, they just pull it down and they know exactly where they are, and they just do a minor and they can do it. But I think as far as the basic learning goes, I think we should go back and start all over again. Don't you agree? I mean, you emphasize that.
Yes, sir.
That I think is a very, very important point. I think you made a very nice slide about various places where you should puncture, based on the type of procedure that you're going to do for the particular patient. So it's not we think it's a blind procedure, but I think some of these more specialized procedures, I think you have to learn how to get into, and imaging, and with transesophageal echo to decide exactly where you want to be in the left atrium. So
wonderful point you made, sir. That it's important to learn how to do a pericardiocentesis before you do a BMV. So everybody in the room must know how to do a pericardiocentesis. Only then one proceeds for the BMV, and it's absolutely mandatory to have an echo machine in the room at the time of doing the BMV, so that you're able to identify and sort out the problem quickly. Sir, sorry, I interrupted you. Sir.
Sorry, the question on the chat box, if you can take that.
And also, I think the other important thing is also to keep the patient reasonably, otherwise when you puncture, if you're not kept the patient well, I mean, I know you don't want to give too much of hydration, but at the same time, reasonably hydrated. But otherwise, when when you push there is a tendency to suddenly cause air embolism. I think that's something else that you have to be very careful about.
Yes, sir. Yes, sir. So the question in the chat box was, is there anything else apart from the broken ground needle to perform a transseptal puncture? I thought I touched upon it, that one can use the reverse end of an 014 wire or an RF ablation catheter, which can be, if it's the Bovie catheter, it can be touched to the hub of the needle and that will go through. Or else you can keep the, with imaging, you can keep the sheath there and take an RF ablation catheter right in under imaging. So, but what most people do is to use either the needle hub with the Bovie catheter, just touch the hub of the needle and it will go through the interatrial septum. Especially in situations where you get a tenting and you're not able to go through, it's always better to use an RF ablation or the reverse end of the 014 wire or the safe sept wire if it's available. The safe sept wire I've seen and handled, it's extremely friendly to use and extremely, how do you say, very, very safe, because the moment it crosses, it immediately kind of makes a U and then you can't perforate or you can't lacerate anything with that U. So it's extremely safe to do it with that.
Hi, Dr. Swamy. That was a nice presentation. This is Dr. Nagaraj Desai.
Good evening, sir. Please go ahead.
Good evening. Have you done mitral valvotomy for Lutembashi through the atrial septal defect and close the AST?
So I have, but I haven't been brave enough to do it at the same setting. We've always done them at two different settings. I know people who reported at the same setting, but we are not very comfortable doing that. And we've done two cases. They are about 8 years apart. And one was a very young patient and the other was not so young. And the second patient, actually, we didn't finally close the ASD. We just did the balloon mitral valvuloplasty and left it.
One interesting point that I wanted to kind of highlight is it possible to get across mitral valve using the atrial septal defect as a kind of a site to go to the LA, or is it difficult to go across into the mitral valve?
No, it's not at all difficult. The only thing is that the anatomy sometimes is a little distorted. So one has to be aware of that. And it's not a bad idea to use the echocardiography machine if it's available. It's in fact, I had a presentation on one of these webinars in which I've shown one patient like that. I don't know if anyway, it's possible, it's not difficult, but it's not as straightforward as it is crossing when you have an intact interatrial septum. That is true.
Yeah, because that is so tempting for us to cross the AST when it is there, rather than having a separate puncture and try and cross the atrial septum. Another question I had was about repeat punctures. In case you're unsuccessful at first attempt, and the injection is into, rather the contrast is heading back into the atrial septum. Would you like to kind of repeat, and how often or how many times you would like to puncture and try and get across into the left atrium?
So I assume that it's on the same day that you have tried and you have
yes,
across?
Yeah. I mean, minutes apart, I guess, senior, younger colleague does it and he doesn't successful, and senior colleague comes in and he wants to do it second time, third time, fourth time. How does it sound to you?
Well, first of all, you need to sort out why you're not being successful. There's no point in doing the same thing over and over again and hoping that you will succeed. You must, it's important to figure out why we're not able to succeed. So possibilities are three: either the interatrial septum anatomy itself is distorted, or we are hitting the thick part of the septum and our needle is not going through, or the interatrial septum is so thin that you are tenting it, you are not able to puncture. So all three have, different ways of getting past them, but you must actually make out what the problem is. Otherwise, just trying to do the same thing over and over again, we are not going to get. So after the second attempt, I would definitely take the help of some kind of imaging to see why we are not able to do it. And 4 and 5 and 6 is a recipe for disaster, if you ask me.
I'm trying to kind of recollect my days of pre-echocardiographic era, wherein the use of echocardiography was not so often to puncture the atrial septum. And it used to be always a difficult proposition. You inject, you think that you are across the septum and you give a small injection, the contrast holds back into the atrial septum, and to do the repeat puncture or not is the question.
No, there is no problem. If one doesn't have an echocardiogram and you have only fluoroscopy, that's why we should go back to what our seniors and teachers used to do. You do an RAO angiogram or you do a PA angiogram and define where the interatrial septum is. So you have to solve the problem. We can't keep doing the same thing over and over again. I mean, that's my message. Even without an echocardiogram, I mean, of course, today everybody has an echo, but in case one is not, if sometimes even with an echo, if you have a, very, very high LA pressure and the atrium is bulging into the RA, sometimes it's difficult to hit the fossa. To make that, it's better to take a pigtail shot of the right atrium in an LAO view, or take a PA shot in an LAO view and see where the interatrial septum is, and then make out where you need to puncture. That's what I would say. I wouldn't keep trying to do the same thing 5, 6, 7 times.
Thank you.
I don't know if.
Thank you so much for that wonderful lecture, and then I enjoyed listening to you. Thank you.
There's one more question in the chat box, Ajay.
How to bail out if aorta is inadvertently entered? All right. So there was another set of complications. If we have hit the aorta only with the needle, you can just withdraw and wait. And if there is no problem, you can back off. But if one has entered with the dilator or the sheath, then we're in big trouble. The best thing is either to leave it there. So I will give, there is one case report of somebody having closed it with a device, with a small device. They've entered the aorta with the dilator, realized they were in the aorta, put in the sheath across the dilator, put in the device and came out, and the patient survived, at least till the publication of the article. After that, I don't know what happened. But otherwise, one needs to put in the sheath or the dilator and take the patient to the OT, because if one has gone in with the dilator, it is very unlikely that it will close on its own. The needle alone is fine. And how to confirm balloon position while pull back from LV to LA at mitral valve. So that's, as they say, out of syllabus. But simple thing is that the balloon is going to be absolutely free. You have to take the balloon to the apex, make sure that it is moving freely, and then pull it back. If it is not, and it is caught somewhere at the mitral valve, it's always better to come back into the LA and try to cross again into the LV, so that one is absolutely sure. If the balloon in the half inflated position can reach the apex freely, it's very unlikely, or it's not at all likely that it is through the chordate. But having said that, this is a blind procedure. Once in a while, you're going to have an MR. Important thing is to finish the procedure. If you have taken away the gradient between the LA and the LV, most of the time patients will tolerate this well. If you are really badly stuck, you can dilate the interatrial septum as well and then wait for some time. How to bail out if aorta doesn't? I think all the questions are answered, sir.
Yeah, correct. Thank you, Ajay. Yeah.
Yes, sir.
Next.
Any more questions?
Nothing there. Ajay, I just saw one, it's just a theoretical thing. The transient ST elevation you mentioned due to embolic phenomena. You also mentioned it could be due to something like basal-gyrus reflex.
Yes.
A lot of vagal network in that area.
Absolutely.
It constantly goes up and comes down. It basically is inferior wall ST segment elevation, inferior wall.
Yes. Yes.
I think with that, Ranga, I could conclude.
I think with this, I think it was a very useful session. It helped us to revisit the transseptal puncture, both in terms of theory and practice. It's very useful practical tips by somebody who has been at this for many years. And I think all the trainees who are coming in the future will have to learn this. They have to be in cardiology and doing structural heart disease or any of these other or electrophysiology. This will become an essential part of our training. I thank Ajay for a magnificent, beautifully illustrated talk with nice pictures and very practical points. Thank you, Ajay. I think all the people here would definitely give you a big hand for that, and thank you.